Rheumatoid arthritis is defined by the immune system's attack on our skeleton. Microscopic views of the joint space show aggressive cells infiltrating the synovium, chewing through cartilage and eroding the bone itself. Rheumatoid arthritis is a systemic inflammatory disorder. It produces autoantibodies, like rheumatoid factor, that circulate through the bloodstream, reaching tissues and organs far beyond the knuckles or the knees. These circulating autoantibodies frequently target the lungs. Pulmonary involvement is a leading extra-articular manifestation of the disease and a significant driver of mortality. Because joint pain is visible and immediate, it often creates diagnostic tunnel vision. If a clinician focuses only on the hands and wrists, they risk missing the silent, progressive damage occurring inside the chest. Managing rheumatoid arthritis requires a shift in perspective. It is a systemic threat that, if left unchecked, can gradually destroy the patient's ability to breathe. If we zoom past the joints and travel down the airway, we reach the terminal bronchioles and the golden-hued alveoli. These microscopic sacs are where gas exchange occurs. This tissue network is known as the interstitium. When autoimmune inflammation reaches this space, it triggers a fibrotic cascade. Delicate gas exchange surfaces are completely replaced by ribflex scar tissue, converting flexible air sacs into permanently dysfunctional barriers. This visualization shows the usual interstitial pneumonia, or UIP pattern. Healthy alveolar walls are overtaken by a thick, rigid collagen network, resembling a honeycomb. Because this web is stiff, the lung fails to stretch during inhalation, blocking oxygen and causing severe exertional dyspnea. In RA-associated ILD, the systemic inflammation has resulted in an irreversible remodeling of the lung's foundation. What began as a joint disorder has become permanent architectural damage. Autoimmune inflammation also targets the bronchial tubes. The chronic inflammatory process severely weakens the structural integrity of the airway walls until they become permanently widened. This destruction creates gaping airway tunnels, known as bronchiectasis. Unable to clear mucus effectively, these tubes become prime sites for chronic cough and recurring infections. Deeper within the lung parenchyma, the disease can manifest as rheumatoid nodules. These can appear on imaging as solitary masses or multiple small clusters. Under a microscope, these nodules have a specific histology. The center consists of fibrinoid necrosis, a core of dead tissue surrounded by a defensive wall of elongated immune cells called palisading histiocytes. These internal lung nodules share a structural identity with the subcutaneous nodules found on a patient's elbows, heels, or other pressure points. Whether damage is in the airways, the parenchyma, or the joints, it carries the same inflammatory fingerprint. The location changes, but the underlying mechanism remains the same. At the lung bases, inflammation can spread to the pleura, the thin membrane lining the chest cavity. This inflammatory process often leads to a unilateral pleural effusion, where thick fluid pools heavily around one lung. This fluid carries a specific chemical signature that distinguishes it from heart failure or simple infection. This lab report shows an exudative fluid with high protein and LDH. The key diagnostic markers are glucose below 30 and a pH below 7.0. The pleura acts as a metabolic mirror. Highly active inflammatory cells consume available glucose, driving the fluid's pH into an acidic range. While autoimmune destruction is usually slow and diffuse, a chest X-ray might occasionally show a dense, dark cloud filling a single lobe. This lobar infiltrate is never a direct consequence of rheumatoid arthritis. As this comparison shows, while nodules and scarring are autoimmune in nature, a localized lobar infiltrate points toward an acute bacterial infection. Patients with rheumatoid arthritis are uniquely vulnerable to these infections because of the very drugs used to treat their joints. The biologic agents and immunosuppressants that stop joint destruction also disable the body's ability to clear a bacterial pneumonia. Managing these patients requires balancing two distinct threats: the slow, smoldering burn of autoimmune lung damage and the sudden fire of an opportunistic infection. By recognizing these systemic risks early, we can look past the joints to protect the patient's foundation, ensuring that the treatment for their arthritis doesn't leave them defenseless against the next threat.